Good afternoon. Welcome to Born Rounds. My name is Dana Sidney, and I am one of the Born Midwifery Coordinators. On behalf of Born Ontario, I would like to welcome you to our provincial rounds, Place of Birth, the Tale of Two Studies. A few logistics before we start. A question and answer period will occur at the end of the presentation. Please type your question into the chat box in the lower left-hand corner of your screen, and feel free to enter a question at any time during the presentation, and we will review them when the presentation is complete. As you've heard, these rounds are being recorded and will be posted to the Born Ontario website. Our presenter today is Dr. Eileen Hutton. Welcome, Dr. Hutton. Dr. Hutton is Assistant Dean at the Faculty of Health Sciences and Director of Midwifery at McMaster University in Hamilton, Ontario. She's also Professor in the Department of Obstetrics and Gynecology. Dr. Hutton held a part-time endowed chair position from 2010 to 2015 as Professor of Midwifery Science at, I forgot to check the pronunciation, Vrije University in Amsterdam, the Netherlands. Her undergraduate degree is from Queen's University School of Nursing, and she's also a graduate of the University of Toronto School of Nursing with a master's and Institute of Medical Science Clinical Epidemiology with a PhD. I will now turn it over to Dr. Hutton.
Great. Thanks so much, Dana, and thank you for the introduction and the opportunity to really talk about these two studies that came out in December of 2015. I'm not sure that I can.
Yeah, you just advance the slide. I can see the second slide now. It might just be a little bit delayed on your side.
Okay.
But you were able to advance it.
Okay, I can't see what it says, so that's a problem.
We're on the third slide. It says hospital birth.
Okay, can we go to the first slide?
Sure.
And can you convince it to let me see it? Do I need to do something different for my setup?
No, as long as you're logged in as moderator, you should be able to see everything. Like I said, there might be a slight delay on your end. Sometimes the slides are delayed. So if you wanted, I could advance the slides as you speak, whatever you're most comfortable with.
Okay, can you go to the first of my slides?
Sure, I'm on the first page right now. It just says the Tale of Two Studies. Would you like me to advance to the next one?
Sure.
Okay.
I've got
so
them
it says hospital birth. Prior to 1900, virtually all births took place outside of the hospital.
Mm-hmm. I can get you to read.
You could also just watch your slides and just tell Val when to advance. So just use your slides.
I'm going to do that. I can't.
I know that the technology takes a lot of getting used to.
Okay, hold on 2 seconds. I just need to open the slides. So sorry for people who are listening in. Okay, so this is, as I said, a presentation looking at the outcomes from two particular studies looking at out-of-hospital births. And if we think about hospital birth and how birth has ended up there, it's interesting to consider that prior to 1900, almost all births in Canada took place outside of the hospital setting. We move to the next slide. We can see that in Canada, by 1940, birth had certainly begun to transition into the hospital setting. In British Columbia, 1940, 84% of births occurred in hospital, 73% in Alberta, 62% in Ontario, 16% in Quebec, and 26% in PEI. So quite a variation. Apparently the Westerners were the early adopters to the notion of hospital birth. But we certainly see a transition, and by the time we get into the 1960s and 70s, almost all births were occurring in the hospital setting. Next slide shows that at the same time as birth was moving into hospital, we saw quite a dramatic drop in stillbirths. This slide shows data from StatsCan from 1921 to 1974, and that downward trend was similar also for neonatal death and for maternal mortality. So we're seeing certainly in the eyes of many an association between hospital birth and the shift that we see towards improved outcomes for mothers and babies. So the question that remains is whether moving birth into hospital was associated or whether there was a causal relationship between moving birth to the hospitals and the improved outcomes for babies and mothers. The next slide looks at some of the challenges of studying home birth. We know that there have been a number of studies published looking at outcomes of home birth. The ideal way of studying this, of course, would be to do a randomized controlled trial. And despite it being the ideal methodology, we know that it's likely not feasible. There have been two quite small randomized controlled trials that were done, one in England, which recruited, I think, maybe 6 or 7 women. The results of that study indicated that they felt that it was feasible to do an RCT. Subsequent to that, there was an attempt to do a randomized controlled trial in the Netherlands, where you would think that if it could be done anywhere, it could be done there, where a large proportion of the population chooses to have their babies at home. However, that study was really over a period of about a year unable to recruit many women at all. I think they had it was again a very, very small number of women able to be recruited, and they changed their study design and looked at other methods of considering home birth outcomes. The challenge with looking at home birth is that we're typically looking at a population of healthy, low-risk women, so the outcomes that people are concerned about are very infrequent. Therefore, we need really large samples, and as I've said, in terms of feasibility, women are not really likely to enroll in a randomized controlled trial that's going to have a flip of the coin or something equivalent to that determine where they're going to have their babies. So the next slide looks at some of the challenges of studying home birth again. The next best design to a randomized controlled trial is cohort studies. And again, we ideally would have studies with large samples, and the challenges up until fairly recently have been to have to get those adequate sample sizes, because in most Western countries the home birth rate has dropped off to be very low. So next slide. Of the many studies that have been done, we have small sample sizes typically. Often there's been no comparison group, so it's a single cohort with no group to compare the outcomes to, or the studies have compared their outcomes with national statistics or other database statistics, which doesn't take into account a number of variables that are likely important in interpreting the findings. Studies have often, especially the older studies, going back 15 to 20 years, often included unplanned, unassisted home births and home births amongst high-risk populations. So those are some of the challenges that have been faced in looking at the literature that's out there. We know in the last few years we've had some quite good studies that have been published, including several studies from Canada. But in December of 2015, 2 studies were published, and I think that's the focus of today's presentation. The first of these was the study that I published with the group here at McMaster, and looked at the outcomes associated with planned place of birth amongst women with low-risk pregnancies. The second study was a study that is from Oregon, the state of Oregon in the United States, and looked at planned out-of-hospital birth and birth outcomes. So 2 studies apparently reporting on similar outcomes, both published in high-end journals. The Canadian study was published in the Canadian Medical Association Journal, and the Oregon study was published in the New England Journal of Medicine. These studies came up with quite different conclusions. I'm whipping through the slides here. How are you doing on the slide forwarding end of it?
I think it's fine.
Okay.
We've now got the first, we've got your paper up.
Okay, well, you should move forward 2 slides. You should see the studies with the red boxes around the conclusions.
Yep.
Okay, now we go to the next slide. The first, the Canadian study's conclusion stated that compared with planned hospital birth, planned home birth was not associated with a difference in serious adverse neonatal outcomes. Next slide. The American study reported that perinatal mortality was higher with planned out-of-hospital birth than with planned in-hospital birth, with an adjusted odds ratio of 2.43, which means that there was almost, 2.5-fold increase in the rate of perinatal mortality when babies were born at home. But they concluded that the absolute risk of death was low in both settings. Next slide. So in the Canadian study, I'm going to talk now a little bit about the Ontario study and give you some of the details from that study. The Canadian study was based on data from the Ontario Midwifery Program of the Ontario Ministry of Health and Long-Term Care, and that data has, since the time that it was originally collected, now is housed at Bourne. And we used the data from the years 2006 to 2009, so a 3-year period. Next slide. The primary purpose of the study was to determine the risk of stillbirth or neonatal death or serious neonatal morbidity amongst low-risk women whose deliveries were attended by midwives and who had a planned home birth at the onset of labor, compared with women of low obstetrical risk who planned a hospital birth at the onset of labor. The study design, next slide, is a cohort study. We matched the women in the home birth group on parity with the women that we included in the control group, because we know that the outcomes for nulliparous women are different than outcomes for women of higher order parity. So unless parity is matched in the 2 groups, the outcomes are biased. And we used the validated database with just over 54,000 midwife-attended births over that 3-year period. Next slide. A study protocol was designed. We got ethics approval from McMaster University and then made an application to the Ontario Midwifery Program at the Ministry of Health and Long-Term Care for the data. We signed a contract with them. Then we cleaned the data, which is an important step in the process to ensure that the data that we're working with really reflects what happened in the population. And we used SPSS as the statistical package to analyze the data. Next slide. We included all of the planned home births in Ontario from 2006 to 2009, which was 11,493. And in the paper, we also report a meta-analysis of stillbirth and neonatal death within 28 days that included all home births from 2003 to 2009. So we pulled in the data from a prior paper that we had published to look at that important outcome. And in that sample, we had 18,181 women in the home birth, or babies in the home birth group. So the next slide shows the flow chart for how the records were used. So we took the full number of records, and this is a diagram or chart that comes from the publication. We took all of the birth records. We underwent a data cleaning process and excluded things like miscarriages and cases where there was no information about the planned place of birth, for example. And from all of those records, we had 12,045 women where they had indicated that the planned place of birth was home or other or undecided at the time of starting labor. And the reason it was important to include the others and the undecided were that those cases may very well have occurred at home, and we didn't want to eliminate them because we thought it was important to capture what is actually happening in the province. We underwent our logic checks, and in undertaking the logic checks, we identified almost 700 records, 687 records, where the likelihood was that the birth may not have occurred or been planned to occur at home. So there were contraindications for home birth, and that included things like preterm births. So what we did with those, we didn't want, because it's possible that women who had, for example, a birth maybe who went into labor at 36 weeks and 6 days decided that they were going to stay home because they'd planned a home birth. We didn't want to exclude women who in fact, had their births before 37 weeks gestation, but we did take out ones where we thought it was highly unlikely that they would give birth at home. So, and I can't remember, but I think those were births before 28 weeks gestation. And then what we did was to keep the remaining births where there was a contraindication where it was highly unlikely that the birth occurred at home, but where it was indicated. So you'll see that in the box towards the bottom that talks about the sensitivity analysis. So once we ran our main findings, we added those births back in to see whether, in fact, if in fact those births had occurred or were planned at home, did they change the outcomes? So that's maybe a little bit complicated, but that was the way that we worked with the data cleaning and the logic checks. One of the important take-home messages for midwives is in filling out the data forms. It's really important to differentiate between women who are in fact planning the birth to have the birth at home at the outset of labor from those who might have planned at some time in the pregnancy or who desired a home birth but who, because of circumstances, wouldn't be able to have a home birth. So in our analysis plan, we used descriptive statistics for all of the outcomes. We conducted comparative analyses for the primary outcome, and selected outcomes were determined for those outcomes that we had decided ahead of time, and we reported a relative risk of 95% confidence interval. I did advance the slide. I'm not sure if I told you I did that. So now if we start to look at the results, I'm also not sure that I told you that in our study we developed a matched cohort to compare the women having a hospital birth. So in our comparison group, all of the women were women who were attended by midwives but who would have qualified for a home birth, but who chose to have their births in hospital. And then we matched them on parity and on whether they'd had a vaginal birth, whether they were planning a vaginal birth after cesarean. So in terms of the results from this study, we see in both groups that the majority of women were aged 25 to 34, between 65 and 70%. The majority of them lived in southern urban Ontario, so 75% were in the southern cities in Ontario, which is approximates the population of women giving birth, and about 65% were multiparous, having their second or subsequent baby. When we looked at the baseline characteristics, we see that they're similar between the two groups. Sorry, I'm on the next slide. But what we did see is that in the women planning home birth, there was a lower percentage who smoked, 4.3% compared to 5.8%. We saw slightly more breech presentations, 0.3% versus 0%. That's because in the planned hospital birth group, we took a breech presentation out, knowing that it's not that if you have a known breech presentation, you wouldn't be planning to have the baby at home, but we didn't take out all of the breech presentations from the home birth group, knowing that it's possible that a woman could have an undiagnosed breech at home. When we looked at gestational age at birth, there were 0.9% of women in the home birth group who had babies born before 37 weeks gestation compared to 0% in the hospital birth group. Again, the hospital birth group, we only included women who were full-term gestation because that is what we would expect in terms of screening for a home birth. Next slide. If we look at the amongst the women who plan to have their babies at home, 75% actually delivered their babies at home. Of the 25% who moved into hospital to have their babies, 8.8% were transported by ambulance. So in fact, that's 8.8% of the full population. But as you can see, not all women who gave birth in hospital who planned at home transported by ambulance. Around 9% used ambulance transport. When we look at the primary outcome, which was a composite of neonatal or perinatal mortality or serious morbidity, which included babies that had an APGAR of less than 4 at 5 minutes or received positive pressure ventilation along with cardio compressions. So when we look at that composite, we see that there was no difference between babies that were born at home compared to hospital, with 0.4% in both groups. It's 4 per thousand, and both groups reported a very similar perinatal or neonatal mortality rate with a rate of 1 per thousand. The next slide shows the composite as it's provided in the publication, and you can see here the definition again for the composite score, and you can see the rate of the composite outcome by parity. We reported all of our the significant findings or the important findings for the study for nulliparous women and for multiparous women, because if this article is being used by women who are planning home births or by care providers who are providing information to women, it's important to know that the outcomes for women having their first babies is different from those having their subsequent babies. And you can see here, although the overall rate of the composite outcome was 0.4 or 4 per thousand in both groups, the rate for nulliparous women was twice as high at 0.8 and 0.7 respectively for home and hospital, and for nulliparous women was lower, so 0.2 or 2 per thousand for in both groups. So the groups weren't different, but they are different by parity. The next slide shows the outcomes for all of the composite outcome, and then provides all of the breakdown of the composite outcome. And I'm not going to ask you to squint and look at all of those small numbers, just to point out that if you're interested in the details, this information is all in the publication, and you can look to see what the particular components of the primary outcome were. So the next slide. We also saw that women who plan to give birth at home were less likely to experience just about all of the interventions that we looked at. So, for example, labor augmentation was lower at home, 31% versus 39%. So it's a relative risk of 0.79. And women who had augmentation would have, at home, the 31% would mean that the majority of those women would have moved into hospital for augmentation of the labor if they required it. Pharmaceutical pain relief was 16% versus 42%, so a relative risk of 0.39 or 60% decrease. Women at home had lower rates of episiotomy, 4 versus 6%. Fewer assisted vaginal deliveries, 3 versus 5%, and a lower rate of cesarean sections, so 6 versus 8%. I think it's the important thing to remember when we're looking at those outcomes is to know that the women who choose to give birth at home may in fact be motivated differently to avoid some of those outcomes. It's possible that being in the home environment influences how labor progresses, but it's also likely that the women who choose to give birth at home may influence those findings. So a study design like this, a cohort study, has limitations. However, these are minimized in this study, by our large sample size, by the fact that it was done over a fairly short period of time, so the approaches to care haven't changed, and so on. We randomly selected our control group from all of the women who had planned hospital births and were low risk and cared for by midwives. We randomly selected the women, so there was no bias in terms of our selection of those women. And the same midwives provided care for the women in both groups and in both settings. So all of those things make this I would say, a very strong research design, short of being a randomized controlled trial. And we also conclude that the low complication rates that we see in both groups are likely influenced by the midwives being well integrated into the healthcare system, with good access to emergency services, to consultations, to transfer of care. We see what I would suggest is appropriate self-selection by women who choose to have their babies at home, and also appropriate screening by midwives who are working with the women in their planning. The care providers in the Ontario study were all registered midwives in both groups. The women giving birth at home included all women in the data set, so it's a complete data set, and there's no option to sort of pick and choose those outcomes that might be better. And the women giving birth in this study, the comparison group included only low-risk women who would have been eligible for, according to the College of Midwives of Ontario guidelines for home birth. And we control for parity and for prior uterine scar. Sorry, I'm probably going through these slides and you're having a hard time keeping up with me again. I'm on the slide that says women giving birth and says we used frequency matching.
Yep,
of all.
we're there.
Okay, good, thank you. So we used frequency matching of all eligible planned home birth records to get our random sample of eligible planned hospital births. All of the findings are provided by parity, which, as I mentioned earlier, makes it a more useful article, I think, for women and for midwives who are discussing what potential risks and benefits might be. We found no differences for home compared to hospital birth groups for morbidity and mortality outcomes and lower rates of maternal interventions, as we've discussed. Now we're going to look a bit at the paper coming from the New England Journal of Medicine. And this study is a population-based retrospective cohort study that included all of the births in the state of Oregon during the year of 2012 to 2013. The study used birth certificate data, which has got limitations, but I think they have made improvements in that in the birth certificate data in the last number of years. And one of the things they did was to indicate a planned out of hospital birth field so that they could collect data on that. However, their out-of-hospital field variable on their birth certificate forms include both home and hospital births. Both home and birth center births. So they couldn't differentiate those births that were born in hospital following a planned out-of-hospital birth. They couldn't differentiate which of those had started out as planned home and which had started out as planned birth center births. So the way the data is reported to us is by actual home births, actual birth center births, and then the number of births where it was planned out of hospital but occurred in hospital. And if we look at the sample size, although the study is reported as being a very large sample, and in fact it is a large sample when you consider that they included all of the hospital births in Oregon, they have in this study included only 1,968 actual home births, 1,235 actual birth center births, and 601 of a combined either hospital or planned home that occurred in hospital. So in overall a much smaller sample size compared to the Ontario study in terms of the out-of-hospital births. The study assessed perinatal morbidity and mortality, looked at maternal morbidity and obstetrical procedures used according to the planned birth setting. As I've mentioned, the birth couldn't differentiate between home and birthing center births for their overall outcomes. The study did find that for the total planned out-of-hospital birth, the perinatal death rate was 3.9% versus, 3.9 per thousand compared to 1.8 per thousand, which was a statistically significant difference. When they didn't report the findings by parity, but they did do an adjusted comparison, so adjusting for a number of maternal factors, including parity, and their adjusted odds ratio was 2.30. So that's telling us that there was a more than twofold increase in the perinatal death rate if the birth was planned out of hospital. They found similar findings in the neonatal death rate, so a 1.6 per thousand compared to 0.6 deaths per thousand when births were planned out of hospital with an adjusted odds ratio of almost 3. They found no differences in terms of maternal mortality. In neither the Canadian nor the American study were there any cases of maternal mortality reported, and they had no differences in terms of their markers of maternal morbidity. They did find, as the Canadian study found, decreased rates of obstetrical interventions when births were planned at home. The big difference in the two studies is the differences in the outcomes for babies. So what's going on with these studies? Why are we seeing these differences? And what can we take away from them in terms of understanding what's going on? So this is the slide that talks about organization of care. And I think it's important to think about, first of all, who is giving birth, who is attending the birth, and the mechanisms in place to transfer care when that's required. And if we look at the next slide, it compares the maternal characteristics between the two studies. And you can see in the Ontario study, typically women were low risk, according to the College of Midwives of Ontario, a definition for women giving birth at home. In the American study, we had small percentages, but some evidence of chronic hypertension at a rate of 0.2%, gestational hypertension at 0.7%, and gestational diabetes at a rate of 1.7%. So again, small numbers, but I think it's important to recognize that when you look at that study, if you look at the outcomes for the women who gave birth in hospital, who had planned to have an out-of-hospital birth, the representation of these numbers was even higher. So it's clear that the women who have got complications of pregnancy were contributing to the poorer outcomes in that group. In the Ontario group, we had 1.6% of women who were post-dates, and in the American study, 4.9%. When we look at another important factor, we don't know in Ontario that all women had OHIP coverage, and it's likely that we had some women who may not have had OHIP coverage, but I would suggest that number is fairly small. In the Oregon study, 45% of women planning home birth were self-pay, so they had no health insurance. And that's compared to the planned hospital birth group where there was 1%. So a very big difference in the financial side of access to care. When we look at the care providers in Ontario, registered midwives attended all of the births in both the home and the hospital birth setting. When we looked at Oregon, there was quite a variety of care providers that were listed as providing care. Certified nurse midwives made up 10%. Licensed midwives were 55%. Naturopaths were 19%. Midwives with no credentials, 13%. And family members, 4%. So a very big difference in terms of the profile of care providers at home. And I would suggest that this might make it fairly confusing for obstetricians or pediatricians who were on the receiving end of transfers to know who the care providers were and what they were dealing with. In terms of the transfer rates that we see, in Ontario we had 25% of the planned home births where women gave birth in hospital. In Oregon, 16%. And I would suggest that it's possible that there were women in Oregon who may have benefited from a transfer to hospital who, in fact, didn't get there. So in terms of organization of care, in the Oregon study, we had a relatively lower rate of transfer of care. We had inclusion of women at higher obstetrical risk and a variety of regulated and non-regulated care providers providing the out-of-hospital birth care. All of this suggests to me that home birth is less well integrated in the Oregon healthcare system, and I would suggest that, in fact, that the organization of care has made a large contribution to the difference that we see in the outcome rates between the two studies. In the studies, I think it's important also, the studies I don't think are directly comparable in terms of who's giving birth in hospital, for example, but in the Ontario study, our perinatal and neonatal mortality rate up to 28 days was 1 per 1,000, and in the American study, in both their perinatal mortality rate alone and their neonatal mortality rate alone is higher than that rate for the by a reasonably high component. So even their hospital births have higher mortality rates for infants than our home birth rates, which is an interesting observation. If we look at the next slide, it just talks about what do registered midwives, what does it mean in terms of care in Ontario. So the next slide looks at the College of Midwifery website. This is Ontario College of Midwives and looks at the standards of practice, and I've just highlighted on this slide 3 particular standards that would pertain to home birth. So I think when you look at having a system where midwives are regulated, you can see that there's a standardization of the kind of care that's expected at home. The next slide is taken from British Columbia, the College of Midwives of BC, only because they put all of their required equipment for home birth on one page, which makes it nice if you're trying to put a slide together. But this gives you an idea of the kinds of equipment, medications, and supplies that midwives are required by their regulatory body to bring to a home birth. So, when we think about home birth, in the context of a regulated system, it's a very well prescribed event. And when I describe a home birth to women, I would typically say that midwives providing birth care at home have the equipment that's not dissimilar to having a birth in a level 1 hospital in the province. This is a midwife from London, Ontario, Kathy Wilson, bringing in her home birth supplies. And I just have these slides that she gave me a number of years ago now to show what a home birth setup looks like. So when we're looking at birth at home, it's a pretty well organized and set up to do emergency intervention if it's required. You can see here the dresser that's been converted into our supply area. You have the supplies laid out for the birth itself. In the center of the dresser, you can see the equipment for monitoring the baby, and to the at the far end, you'll see the equipment for resuscitation. So oxygen, suction, bag, and mask is all there and ready to go. So in Ontario, our findings replicate the findings from earlier studies from British Columbia. There's been 2 studies from the BC midwives in 2002 and 2009. Both of those studies had very similar findings to our recent paper. The large study coming out of the Netherlands by De Jong that was published in 2009 also has very similar findings, and again the large UK birthplace study that was published in 2013 also found that home birth outcomes for women planning home births were safe for women and for their babies. So I think we can conclude that in settings where home birth has been well integrated, that the outcomes for mothers and babies are safe, and that the association between moving births to hospital and the decrease in stillbirth and rates and perinatal and neonatal mortality rates are not, there's no causal relationship. The Canadian finding confirms that, yes, as in other settings, when birth is supported by well-trained midwives, the outcomes are good. So the key points: there are differences depending on setting. For Canadians, the perinatal and neonatal outcomes and maternal outcomes in home and hospital are comparable. I think it's important, however, to recognize that we shouldn't generalize these findings to settings where home birth is not well integrated. And equally, I don't think we can take the study findings from the New England Journal and generalize them to Canada, because our system here is very different, and our outcomes, as I hope I've pointed out to you today, are improved. These last 2 slides are from a colleague of mine, Justice Hofmeyr from South Africa, who's done a lot of research and is one of my mentors. He says that planned birth at home has decreased in many countries, mainly because of perception that it is not safe. The risk of complications related to lack of medical facilities in home births needs to be weighed against the risk of complications related to medical interventions and mishaps in institutional births. And the lower the intrinsic risk of an individual, the more likely are the relative risks to favor home birth. And at present, there does not appear to be any robust evidence to support insistence on hospital birth for low-risk women who prefer to give birth at home. So, thank you very much for listening in. And this is my declaration of conflict of interest. These are 3 of my 4 grandchildren who were born at home. So, I think we can open questions.
Thank you, Dr. Hutton. Beautiful photograph to finish with. Captures, although it doesn't look like a newborn there, unless you have a very large grandchild.
But large.
Yeah, captures the essence of the beauty of home birth. We welcome any questions that could be typed into the chat box. I don't see any at the moment. I do have a quick question about a very small point. When you talked about the interventions, with augmentation, were you just talking about oxytocin augmentation, or were you looking at membranes also?
When I put the slide together, I was thinking it was oxytocin, but I would need to go back and check because the rate of 31% is higher than the transport rate to hospital, so it wouldn't. It doesn't make sense that it would be only oxytocin because we're obviously not using oxytocin induction at home.
Thank you.
I can't. I should have brought the paper with me. Actually, in the paper we may have the breakdown. I know we certainly have that data, so we could pull that up if anyone was interested in it. The breakdown of augmentation using rupture of membranes versus oxytocin.
We have a question in the chat box. Just wondering if there was a reason for the choice of timing of the cohort, 2006 to 2009.
Sorry, can you say that again?
Just wondering if there's a reason for choice of the timing of the cohort, why the years were 2006 to 2009.
Yes, very straightforward answer. First of all, we did a study on the data from 2003 to 6. And at the time we did that, that was the most recent data that was available. And this study we used the data from 2006 to 9 because we completed the data up to 2006. So it was the next most available data when we did the study. I think in doing this study, the cleaning of the data took a very long time. It was probably close to a year getting the data set completely cleaned and ready to use. So, and the time frame for getting the contracts and getting it signed over from the ministry, as well as getting ethics here, which was really interesting. It took us a very long time, I think, because they were changing between merging their ethics boards here, but it sat with ethics for more than 6 months here. So there's many delays, which always is challenging in terms of trying to keep data current and undertaking studies.
Did you find any significant differences between the two studies? Yours, the earlier and the more recent.
I was looking at that just as I was putting these slides together, actually. There's a few differences, a few rates of things that I would say maybe are creeping up a little bit, but nothing too substantive. By and large, the rates are very, very similar. If you compare the studies and you look at the primary outcomes, you'll notice in the 2003 to 6 study, the rates of the primary outcome are much higher. It's 2.4%, I think, or 2.4% in both groups, and that's because we included admission to NICU, but in the 2006 to 9 data, we didn't have that information available, so we couldn't include that as part of the morbidity in the neonates. But there was no difference in the first study in terms of the between group difference, and we also saw no difference between groups in the second study.
Another question in the box: any similar studies from other provinces with well-integrated midwifery programs?
The only other
British Columbia.
Yeah, the only other province that I'm aware of are the studies that have come out of British Columbia, and their most recent one I think was published in 2009. But I would expect that we will see additional studies coming out of BC. They're probably the next largest province in terms of midwifery birth numbers, although their numbers are much smaller than Ontario. So Ontario's got by far the largest number of midwives practicing and therefore the largest number of home births. Although as a percentage of the births, we're not as high as BC.
Lots of positive comments coming in the chat box. Are there any further questions? Okay, I think we will sign off and leave you with 10 extra minutes in your lunch hour.
Great.
Thank you very much, Dr. Hutton. A couple more questions coming in. Any plans for follow-up, including birth center births, is the first question. And the second is, what do you think the province of Ontario should do with these findings?
Well, I think so. The first question: any plans going forward? I understand that there's 3 more years of Ontario midwifery program data that is sort of what we describe as legacy data before we move into the born data sets. And I think it will be important that those 3 years, so it's the years between 2009 and 12. I think it's important to study those as well. I think it's important going forward for us to continue to do these studies, partly because despite the fact that this study has had a huge amount of attention and I think is very reassuring. I think we will need to continue to provide reassuring outcomes for quite a long time before home birth becomes I would say normalized. So I think those studies will be important. I think the other thing, as we get more data, more years of data going forward, we can begin to look at things like trends. So the question you asked, did I see a difference between the 2 studies that we've done? You could look at the 2 studies and say, well, yes, we see a difference, but it's hard to draw any kinds of conclusions based on 2 data points. But if we have 9 years of data, for example, we could look at it on a year-to-year basis and look at patterns and trends. Certainly, there's there's been comments that as midwifery has grown in Ontario, we have proportionately more less experienced midwives providing care. And does that make a difference? Does that mean that more midwives are transferring care more often, for example? So those are all really interesting questions. I would say based on what we've seen in these studies, I don't think that that's the case, but we could use other more sophisticated study designs to look at those kinds of questions, which I think are important kinds of questions to look at. So I think I always have lots of plans. The limitation of funding. So,
the second question was about what Ontario should do with these findings.
Yeah, I think certainly Ontario as a province should feel very reassured about the care that women are getting from midwives. I would say both at home and in hospital. The outcomes are very good. I mean, they're stellar. So I think midwives should feel very good about the care they're providing. And I think the province, in terms of evaluating it's one way to to contribute to the evaluation of the midwifery program. Just one second. And I would say that it's a very good indicator, a strong indicator that the midwifery program in Ontario is successfully providing the kind of care that we would want women to be receiving.
We have one more question in the box. Are we seeing more home births due to the amount of self-pay immigrants being supported by midwives? So I guess the question's referring to the fact that midwives are funded to care for the uninsured or the without OHIP.
Yes. We can't tell that from this study, and I'm not sure that we have a good way to track that from the data set that we have.
We are tracking now in born OHIP status.
Yeah,
during
so that will be useful going forward to be able to look at. And I certainly know that women who are self-pay, certainly in my experience, and it goes back a little ways, but women who were self-pay would very often be interested in home birth because it's obviously for them less expensive. But I think, again, in our circumstance, even with self-pay, pay, if midwives are governed by the standards of practice from the College of Midwives, then the care shouldn't substantially change in terms of outcomes. So the outcomes one would anticipate shouldn't be dramatically influenced by that, in a way that I think they may be in the U.S. setting.
Thank you again, and thank you
You're
all
welcome,
for your
and
time.
thank you
attended.
for interest and the opportunity.
Just one final announcement. Our next scheduled rounds will be in May, so there will be no born rounds in April. The date is May 19th, and our speaker was referenced significantly during this talk today. It will be Dr. Patricia Jansen, who's the co-theme lead of maternal child health at the UBC School of Population and Public Health in Vancouver. And she will be discussing her recent paper on vaginal birth after cesarean outcomes in British Columbia. So we look forward to reconvening on May 19th. Thank you very much. And just a reminder that this webinar will be posted on our website. So if anyone's interested who wants to watch again or who wasn't able to attend, you can spread the word. Thank you again, Dr. Hutton, and everyone who attended today.
Great, thanks.